children's home and community-based services workflow. Our presenters today are Faith Schlesinger and Colette Pullen from the New York State Department of Health, and they have with them a team of experts from all the different child serving systems across New York State. Before we get started, I want to take a minute to orient everyone to the WebEx system so you know how to participate in today's event. If you haven't done so already, it's probably best for you to call in to be able to hear clearly on the audio portion of the call. And if you're connected via your computer, instead, if you click on the Event Info tab, you'll see the call-in information. You'll also find that same call-in information in the chat box. If you have any technical issues during the webinar, please chat to our MCTAC host, and you'll find that person in the drop-down menu in the chat box. If you aren't seeing your chat box right now, if you look on the upper right side of your screen, you'll see a speech bubble, and underneath it, it says chat. If you click on that, the chat box will open, and you'll again see a send to drop-down where you can select who you want to chat to. We encourage everyone to chat questions in throughout the webinar. Don't wait till the end because it's helpful to our presenters to see the questions that you have along the way. And we will take questions, if time allows, at the end of the webinar. So without further ado, I'm going to turn this over to Colette and Faith.
Good morning, everyone. This is Colette Pullen with the Department of Health. And thank you to MCTAC for hosting this webinar. And as was just mentioned, we have a whole host of state partners in the room that will has been working very diligently to get information out to the field and has assisted with this webinar. So this specific webinar is regarding the HCBS workflow. It is our intent to make sure that this webinar is immediately posted. It's being recorded by MCTAC on the DOH website as well as the MCTAC website, and it will be sent out to all the listservs through MCTAC and DOH to ensure that everyone receives the slide deck. It is our intent that people get to review the slide deck on their own and be able to comment, so there will be a comment phase. I was having difficulty moving the page. All right. So our overall purpose, again, is to review the HCBS workflow. How do you get to the HCBS workflow from eligibility and getting your plan of care developed and then approved if appropriate. So as I mentioned, it's our overview of the draft process. We work really hard here at the state to take into consideration the current waiver processes that are happening today. We're not trying to recreate any forms or anything like that besides tweaking them. Lessons learned from the adult HCBS implementation. So we heard a lot of feedback over the last year or so that it was a little complicated on the adult side, and they are now tweaking and trying to streamline it and really looking at where we could streamline time frames and processes so that getting easier access for children and families to the HCBS services. As I mentioned, we'll be sending out these slide decks and posting them. It's our hope that you'll review them and then comment by Wednesday, May 30th. I know that's a very short timeline. It's a 1 week away. We have lots to do before implementation in January 19. You'll see the link there to the mailbox, and if you could just make sure, we get a lot of emails, that you highlight in the subject line the HCBS workflow comments. That would be muchly appreciated. Again, we are really just focused today on the HCBS workflow. So you'll see there that we are planning an HCBS eligibility determination process. We will walk you through that, as well as the role of the independent entity, how they fit in all these processes. We'll talk a little bit today about the independent entity and where they fit within the workflow, but there will be a specific webinar just regarding the independent entity. So we just want to make sure people understand that we know there might be some anxiety and lots of questions out there, but we are planning a host of webinars, in-person trainings coming up. So again, this is an overview for the draft process for health home care managers, the independent entity, Medicaid managed care plans, and HCBS providers, and how they will all work together to determine eligibility and connect children and families to the appropriate services of HCBS. And as I hope that you're all aware, we have a new timeline. So from January 1st, 2019, which is our launch of the transition, to June 30th, the capacity for the 1915C slots today will be all combined to make the HCBS eligibility capacity happen. So as I'm sure you're aware, the 6 waiver services that are listed there will be all combined under the 1115, under one waiver service product, and all the combination of that capacity of those 6 waivers will be combined into what we are calling one capacity management list. Beginning in July 1st of 2019, the capacity limits will be expanded over a 3-year period. So in our previous webinar that's posted, we did go over the new timelines, and so I would reference that for you for all those timelines moving forward. So here at DOH with our state partners, we are developing a process to manage capacity as outlined. We will be working with the current 1915C waiver providers to track every child in a current waiver today and making sure that they transition successfully to health home care management, or should they choose to opt out, they will be tracked with the independent entity prior to January 1st. As you remember, the timeline for transition of the existing waivers are from October 1st, 2018 to December 31st of 2018. No transitioning child from those services who are currently enrolled during this period of time before the end of the year will lose any services. Again, we are working together at the state to make sure not only are we tracking every child and ensuring that they transition successfully with the current 1915C waiver providers, but also to then, starting January 1st, ensure utilization of these services. This will be captured through our UAS system, our Uniform Assessment System that houses the CANS New York today, which will also hold the HCBS eligibility determination. This will assist us in managing capacity. We will make sure that there are clear communication paths for care managers as well as the independent entity to make sure that the appropriate children who need to be connected to HCBS services due to eligibility are clear about whether or not and how to access those services. So I want to talk a little bit about this transition period, as I just mentioned, between October 1st, 2018 and December 31st of 2018. This is when we are transitioning the existing 1915C waiver providers that were just listed, those 6 waiver providers, and those children who are in those services. So I think folks have heard this before. It is our goal to transition all those waiver providers to preserve your expertise in these services to children and to ensure continuity of care and a seamless transition to the 1115 waiver starting January 1st. So it's our goal that you will transition with your children through this time period, and that, again, no child will lose any services as they transition. I want to be very clear that all children need to be transitioned by December 31st, 2018. There will be no exceptions to this, as new rate codes and other mechanisms will be put into place starting January 1st for the new 1115. As I mentioned, we really want to ensure there is continuity of care. So again, I just want to highlight for folks, especially if you're like, how is this going to happen? We'll be launching a number of communications regarding webinars as well as in-person meetings and trainings to walk the 1915C current providers through the process of how you transition your child to the 1115. So we want to assure you that we will be helping you with that and making sure we outline that process for you. But again, our goal here is to preserve continuity of care, and there will be a crosswalk also to services in your current plan of care from your 1915C services to the 1115 to, again, assure that there is continuity of care and services. So children and adolescents who are enrolled in HCBS under the 1915C waiver must transition to health home care management services, or should the individual choose to opt out of comprehensive health home care management, they will be transitioning to the independent entity, as I mentioned, by December 31st. This transition, again, will happen between October and December of this year. And all the children that transition prior to or at December 31st will automatically have a 1-year continued HCBS service based upon the date of the signed and completed Health Home CANS New York. You will not need to do a new HCBS eligibility process. You will not need to do any of the new LOC criteria for these transitioning children. So essentially, the children you have today will be grandfathered in and receive a 1-year LOC HCBS continuation of services. Until December 31st, as I mentioned, all these children need to be transitioned for the effective date of the new launch of the 1115 on January 1st, 2019. Any child or adolescent who is not enrolled in the 1915C HCBS services, including those children who may be on a wait list, will need to be redetermined or be determined HCBS eligible starting January 1st. So it is our goal, and I think all the state partners agree, it is our goal to ensure that every child who can be eligible for HCBS services under the 1915C service array can get eligible within this time frame of October and December, so they can get that continuation of services for 1 year. Otherwise, any new net child will have to be determined by the new criteria, which will be that webinar of the HCBS eligibility determination, as we mentioned, that will be upcoming. So we want to make sure that transitioning providers, when transitioning to health home care management, preparing for the new aligned HCBS and SPA services, as I mentioned, beginning January 2019. We're repeating these dates multiple times so people really get to know them. That the health home care manager, which was previously a 1915C provider, will update and complete a comprehensive plan of care inclusive of your 1915C waiver services identified under the newly aligned service language, title, and information. So we'll essentially take your current plan of care under your current 1915C, and you will transition that plan of care to a health home comprehensive plan of care, and you'll just utilize the new titles, language, or anything that has changed converting to the 1115. You will update frequency, scope, and duration for each of the services as necessary. And if there's any newly identified needs, you will obviously add that to your plan of care, and you will be trained by your local connected health homes of what are the requirements for a health home to ensure that it's a comprehensive plan of care. So these are the 4 steps that will happen that you'll need to take after you transition your child between October and December. As you prepare for the newly aligned comprehensive plan of care, it needs to be inclusive of the HCBS services, and if the child is enrolled in Medicaid managed care, then that transition will also happen in January, in the beginning of January. So if you currently have a plan of care, you will transition it to the new language, and you will update your scope, your frequency, your duration, any additional needs. You will update all of that, and come January, if that child's enrolled in managed care, you will follow the managed care process that we will be outlining to get your plan of care with the managed care plan. I just really want to quickly highlight that we keep saying if a child is transitioning out of health home, that they'll be connected to the independent entity. So our independent entity will be beginning in November of 2018 to assist any child that is transitioning who opts out, whether the child is fee-for-service or in managed care. That is okay. They can be transferred to the independent entity who will assist with their transition of their plan of care, and will either be monitoring and connecting that child or continuing the dialogue with those providers, or will be connecting that child and the plan of care to their Medicaid managed care plan. So after the transition occurs, starting January 1st is the new aligned HCBS services and the new requirement for level of care determination. Children who are already enrolled in Medicaid who are believed to be HCBS eligible and or in need of HCBS will be referred to a health home. Those not enrolled in Medicaid will be referred to the independent entity. So these are these children who are family of one. Health home care managers and the independent entity will work with the child and family and providers to determine HCBS eligibility. The uniform assessment system that houses the CANS New York today will also house the HCBS eligibility determination for LOC-LON. HCBS eligibility of LOC determination is comprised of meeting 3 factors, and we've outlined this before. The individual, the child, needs to meet a target population, the risk factors, and a functional criteria needs to be determined as outlined in our 1115. And we will walk, and in our appendix, we do have those 3 factors in our appendix outlined once again and updated for everyone, so you can reference those instead of trying to find previous webinars. Children who may be eligible for LOC HCBS under one or more of the target populations. However, it's only necessary for the care manager, the independent entity, to pick one target population to pursue HCBS. And here are the target populations for the launch of January. Again, the child has to be in Medicaid under the age of 21 and meet one of these target populations. As I mentioned, this is all outlined in our appendix that you'll have access to. Each target population has specific outlined diagnoses, conditions, or requirements that must be obtained, documented within the individual's case record prior to being able to move forward with the HCBS eligibility determination. So this is kind of like a decision tree process. You need to meet target population first, have the appropriate documentation to be able to move to the next step, which is the risk factors. So once you have identified and worked with the child and family, gathered the appropriate documentation to identify that child under our target population, you'll be able to access then the risk factors. The risk factors for each of the target populations may vary a bit, and again, this is in our appendix as well as in our Children's 1115. Each of the risk factors, however, for each of the target populations requires a licensed practitioner of the healing arts who has the ability to diagnose within his or her scope of practice under state law to determine that the child is at risk of a more restrictive setting, and that HCBS services would be helpful to remediate this risk. The New York State is developing a form, so I know that currently many of the waiver providers have a form or a document to get some type of documentation from a provider and or a licensed provider. We will be utilizing those tools to have one form for moving forward in January of 2019. Once you have completed all of the risk factors, you have obtained the appropriate documentation, you're now moving to the functional criteria, which is a subset of questions from the CANS tool that will determine whether or not the child meets LOC level of care. For developmental disabilities and medically fragile target population in developmental disabilities and a child in foster care, this process is determined by the OPWDD DDRO. So the DDROs will work with the health home care managers and the independent entity to ensure the completion of the HCBS process occurs and that eligibility is known to the IE and the care manager so that they can proceed with development of the plan of care. And again, this information regarding developmental disabilities has been posted previously and is in our appendix. So as I mentioned, this is kind of a decision tree process. However, there are opportunities to kind of streamline them depending on where the child is in the process or how much you know about the child. So we already know there are children in health homes. So there may be information you already aware, you already have a plan of care, you may already have assessments. Children may be and hopefully are already working with providers. So there may be opportunities there as well. The target population and risk factors can be worked on and obtained simultaneously. So you don't, once you learn the tool in the UAS, you don't need to literally do one step at a time. You can gather documentation and ensure that you're completing everything at the same time if you would like. Additionally, as I mentioned, if a child is connected to a service provider, you want to verify if they meet the LPHA requirement, because again, once we develop the form, you can ensure that they are completing that form while you're gathering other documentation. And you'll see through the list of the LPHAs, there's many folks on that list that children already are in contact with or working with already. So hopefully, again, there's information and connectivity that children already have that will streamline this process for you. If the child is already enrolled in a health home with a completed CANS, the CANS may be utilized by the health home care manager to complete the HCBS eligibility determination. You don't actually need to redo those CANS questions because the HCBS is a subset of the questions. So if you already have completed the CANS and your CANS is active, then you can utilize that existing CANS. And additionally, the health home care manager can determine health home and HCBS eligibility separately or simultaneously because documentation is very similar. So if a net new child in Medicaid comes to the health home care manager can determine eligibility for health home and HCBS simultaneously, or they can do it one step at a time depending on the needs of the child and family. HCBS eligibility determination is good for 1 year regardless of the service utilization. So we all know right now the CANS has a timeline of every 6 months, or if there's a significant life event that occurs in a child's life. But HCBS will be good for 1 year. So there will be different triggers to produce your CANS New York on a regular basis of 6 months versus your HCBS eligibility for 1 year. So just quickly, some general requirements, so to speak, that we'll be outlining. So children who are eligible for HCBS are required to have care management and a care plan of their services. Children who are eligible for HCBS are automatically eligible for health home to get that care management services. Children who are in health home are not automatically eligible for HCBS. So we want to make clear that you must go through the HCBS eligibility determination for a child, and that child must meet the level of care, the 3-tier process we just went through to receive HCBS is not automatic. Health home care managers must develop one health home comprehensive plan of care that includes all the services the child needs, inclusive of HCBS services. There should not be 2 separate plans of care. We'll talk later about how you can access HCBS services up front, and if so, they just need to be included in the comprehensive plan of care based on that. And enrolling children who are eligible for HCBS in health home ensures children receive comprehensive plans of care that includes all the services the child needs. If the child opts out of health home, then they receive the independent entity and they receive only an HCBS plan of care. So just some general requirements. The HCBS eligibility determination must be completed face-to-face by the independent entity or the care manager for the child. And we have outlined all the HCBS requirements here for you. Eligibility for children aligned in HCBS equals health home eligibility. So we already mentioned that. Again, just making sure that people understand if a child reaches HCBS eligibility, then they need care management or care coordination for them. HCBS eligibility determination, as we mentioned, is on a yearly determination regardless of the CANS. Should the member who was previously determined HCBS eligible refuse HCBS services or leave HCBS services and later request HCBS services, eligibility determination is not needed. So HCBS is good for 1 year, whether or not the child's accessing those services or not. So the child may be in services or may go to a different type of service and want to postpone HCBS and then come back later. If it's within that 1 year, they are still eligible. A redetermination is not necessary. And just to outline that plans of care must be signed by the child, adolescent, the member, whatever term you want to use, as well as the parent, guardian, legally authorized representative. So this should follow all other health home care management rules regarding who should sign consent Of course, if the child is of age to self-consent or is at an age to understand the plan of care, they should have an opportunity to sign the plan of care. Any reassessments or additions or amendments to the plan of care should have also signatures. The providers that are involved in the multidisciplinary team or is connected to the child later on should obviously be involved in the plan of care development and should have an opportunity to also sign the plan of care. But the plan of care should not be held up for the lack of signatures from providers. Anytime folks are having any difficulties with engaging members or providers for signatures or other reasons, the lead health home, your managed care plans are obviously resources to assist you to move forward with servicing the child. So I'm going to now turn over the workflow. We wanted to set folks up to make sure you understand if you're a transitioning provider, how that will work between October and December 31st, and the general requirements. And now Faith is going to walk you through the actual HCBS workflow.
Hi, and good morning, everybody. You can go to that. Thank you. So what we have set up for you is a 5-step process. This 5-step process, as I'm going to review with you shortly, encompasses both fee-for-service and children enrolled in managed care plans. Similar to things that we noticed about the adult process, we wanted to present this to you in a simplified manner. So these 5 steps encompass, again, whether you're fee-for-service or in managed care, and then we'll conclude with some sort of nuances as it relates to whether or not you're in managed care or in the fee-for-service program. So the first step, as Colette spent time outlining, is in relationship to determining your HCBS eligibility, or as appropriate on the annual basis, being reassessed for your HCBS eligibility. The health home care manager, or the IE, would complete that, and again, that date for completion is whenever the last date of a completed and finalized HCBS eligibility determination was done in the UAS. So step 2 is the development of a plan of care with the child and family and all involved providers. Again, as outlined, if you're a child who's enrolled in a health home, that's going to be a comprehensive plan of care. It's developed in coordination with information from completion of all appropriate assessments, the CANs, the comprehensive assessment most specifically, and the interdisciplinary team members, which is just involving the discussion with the child, their supports, and all involved providers, and meeting all the requirements is set up in the health home program policy with regard to a comprehensive plan of care. If you're being served by the IE, similarly, you'll have a HCBS plan of care, which utilizes continued discussion with the child and their family, all available important supports in the child's life and the involved providers following completion of that HCBS eligibility determination. We really wanted to focus again in identifying that the plan of care is a person-centered discussion with the child and the family, surrounds the strengths and needs of the child, is developmentally appropriate and comprehensive to include the services that they require, and that the plan of care specifically outlines the types of services to be provided to the child and family by their chosen providers. Thank you. So step 3 is referrals to the providers that are made. Family choice, as always, is preserved in this process. So upon completion of the plan of care and the determinations as to what services would be appropriate, the health home care manager or the independent entity is going to work with the family and the managed care as appropriate to identify available providers in the community to obtain those services. This involves getting appropriate consent for those referrals, again, maintaining family choice, maintaining network requirements as appropriate, engaging with the managed care if they're enrolled. The care manager or the IE is going to document those providers within the plan of care, and then if they're enrolled in managed care, that finalized comprehensive assessment or HCBS, comprehensive plan of care or HCBS plan of care for the independent entity, if a child's enrolled in plan, will get forwarded to that managed care plan. The health home care manager or the IE is going to follow up on those referrals to make sure that the family and the providers are engaged, ensuring linkage to the services has occurred, contacting representatives as appropriate throughout that process to ensure completion and that children are in receipt of those services. Step 4 for all is access to those services. So once that referral has been made, and I just again want to stress, while it's being sent to the managed care plan if they're enrolled, that's occurring simultaneously to the completion of that. So once that managed care plan and for a HCBS plan of care, or if you're in fee-for-service, the appropriate providers have been notified and provided that plan of care. The HCBS providers that have been referred to will have their initial meeting with the client, conduct an intake or assessment as appropriate within their scope of practice and the service that they're enlisted in. They'll discuss with the family the appropriate determination of frequency, scope, and duration. So that determination, again, is made based on the assessments completed by the provider in conjunction with discussions with the family and the child. And then that information is going to be communicated back to the health home care manager or the independent entity who's going to update the plan of care with that information. So once that's completed, the final step is that continued ongoing monitoring of the plan of care. All plans of care are required to be reviewed and monitored to ensure that they are comprehensive, integrated, person-centered, that the HCBS listed in the plan of care is appropriate for helping the children attain the goals as identified within that plan of care. The plan of care is also then updated to reflect the changes in HCBS as appropriate, and the revised plan will always be shared if enrolled with the managed care plan. So that's a lot of information, and that process, again, is outlined with some peppering of information if you're fee-for-service or managed care, but ultimately that 5-step process is inclusive of what you will go through regardless of whether you are fee-for-service or in managed care. Now some information specific to if you are enrolled in the managed care plan and in the managed care environment. So the managed care plan is going to promptly be prompted to automatically authorize the HCBS upon notification by the provider that they're engaged in care. And that notification is the requirement that the health home care manager or the IE would submit that plan of care, which lists those specific HCBS prior to the date of the first HCBS appointment. So that serves as notice to the plan and permits that initial authorization of services. So as we said before, that's going to occur simultaneously. There will be simultaneous referral to the individual providers and submission of that plan of care if you're in managed care to the plan. So the initial authorization that's permitted through submission of that plan of care begins that 60-day clock that the managed care plan receives notification from the HCBS provider and automatically authorizes and permits service that includes 96 units or a total of 24 hours of services, not to exceed 60 calendar days of duration. So again, I just want to be clear, because there's a lot of nuance here and a lot of information, that once that's identified, you're able to access services immediately once you've submitted that plan of care to the managed care plan if you're enrolled, so that they are anticipating and expectant of that provider to start a billing process. And once it's identified that that provider has started work with this client, they identify that, and that'll permit the initial authorization of that service to begin, which is that 60-day clock where there is no ability for the managed care plan at that time to deny service. The managed care plan will notify the child, parent, guardian, and legally authorized representative, the HCBS provider, and the health home care manager or the IE of the service authorized and the time frame of that authorization. So review by the managed care plan is required when HCBS exceeds 60 days, 96 units, or 24 hours of service, whichever is first. So again, you get that initial authorization, which allows them to receive services. Essentially, I'll use the word unchecked, so I'm sure my managed care friends don't like that word, but I'll say they won't be able to deny that service for that initial period. Following that initial period, again, 60 days, 96 units, or 24 hours, whichever occurs first, This will then be reviewed and trigger a review, by the managed care plan of those HCBS. The HCBS provider must use the authorization form to submit a request for additional days, units, and hours. The request must recommend, again, that scope, frequency, and duration. That scope, frequency, and duration should also continue to be communicated to the health home care manager or independent entity to update that plan of care as appropriate. To avoid disruption in services, the HCBS provider is encouraged to submit the request as soon as it's apparent that the service is going to exceed those limits. Requests submitted less than 14 days before expiration may not be authorized before runout. So again, make sure that you as a provider are tracking that appropriately, and we encourage you to be able to submit the appropriate forms and documents to the managed care plan at least 14 days prior to the expiration to ensure that the authorization doesn't run out prior to your next service. The managed care plan will review the request and issue a determination through an authorization within authorization request timelines, which is defined within the model contract. The managed care plan may request additional information as related to the service authorization by the HCBS provider. And this, again, to be clear, follows normal protocols that exist when authorization occurs by the managed care plan. So now we're going to spell out some of the specifics as it correlates to being in a fee-for-service environment. So that HCBS plan of care, as is completed in conjunction with the providers and the family, is the service authorization. And the health home care manager and IE will be required to monitor the plan of care services listed in that plan of care. Upon completing referrals, the health home care manager or the independent entity is going to coordinate with the child's parent and guardian, legally authorized representative as appropriate, and referred providers to ensure the plan of care includes the frequency, scope, and duration. So again, it's maintained as parallel to the other authorization process in the sense that you still maintain referral to providers. You start that initial service. It's in conjunction with the family and all providers and appropriate supports working together. And then once the provider, family have a discussion based on their assessments during an initial meeting, they report that frequency, scope, and duration back to the IE or health home care manager to incorporate. But that information as a whole held within that plan of care is the service authorization for those HCBS. The expectation is that the health home care manager or the independent entity will coordinate with that family, child guardian, the child, legally authorized representatives, and appropriate supports to ensure that the appropriate supports and services as it relates to the goals within their plan of care are maintained or discontinued based on the person-centered planning discussion. Fee-for-service service authorizations will be reviewed by the state as part of ongoing monitoring, but to be clear, this means that there is no separated initial authorization period as paralleled within the managed care environment, as the plan of care itself serves as that initial service authorization. So we wanted to highlight that there are specialized processes and more information that will be forthcoming regarding this workflow, specifically for services like respite, where children may need these services on a more emergent basis to ensure that they're able to maintain an appropriate HCBS setting and out of the emergency room or inpatient care. We specifically called out respite here for crisis and plan, but to be clear, in these situations, the state is developing process as it relates to service authorization occurring prior to the completion of a comprehensive plan of care if you are in health home. More details will be coming out on this shortly, but we wanted to let you know that we recognize this and are giving considerations to this as it correlates to HCBS that might divert a child from having to be in the emergency room or inpatient hospitalization. Additional HCBSs are available, which will have additional processes laid out for them, are accessibility modifications, adaptive and assistive equipment, respite, as I mentioned, and non-medical transportation. These are not included, for example, because modifications include fitting procedures, which will again be paralleled to process similar to what exists today to access these services, but these will be called out in separate policy guidance. So you can go. So these slides, as it continues, you're probably familiar with. This is a chart variation to identify the roles of care management and coordination between the health home care manager, the independent entity, and the managed care plan. It's a really helpful visual that outlines some of the nuance that we described at the end of the slide deck. And as we move forward, again, the appendix of this document contains a lot of material, information that correlates to specifics to LOC, LON, information as it relates to the specifics for DD foster care and DD medically fragile children, and information for those children who do opt out of receiving HCBS. This slide deck is going to be made available immediately following, and as mentioned, these comments are due on the information and content of this deck and policy by Wednesday, May 30th, and should be submitted to the DOH Behavioral Health mailbox that's listed there. As identified previously, we will have ongoing information specific to the role of the independent entity and HCBS eligibility determination process. So with that, and the time that we have left, we're going to take some time to take some questions. I just want to remind people you will have the ability through our comment process to email us directly as it correlates to this presentation for more information. So if there's anything we can help spell out for you now to support you in submitting those questions and feedback, we're happy to do that. And I will kick it over to McTack as we start looking and reviewing some of the questions. Thank you so much for your attention today.
So while the presenters review the questions and take a look at the different kinds of feedback that they've gotten during this webinar, they'll be back in just a minute, so hold on. I posted an announcement in the chat box to all the attendees, which gives you the email address that you can use if you are not currently receiving email announcements from the Managed Care Technical Assistance Center. You can email us and we'll easily add you to our listserv so you get those announcements. I know that the presenters mentioned a couple of upcoming webinars, and there will also be some relevant in-person trainings being announced soon. Also, the slides from today will be posted probably tomorrow, if not later today, and a great way to access slides from any of our presentations is to visit the CTAC website and look at the upcoming events, and under that tab you'll find a calendar where right on the same day as the presentation you'll find a link to the slides.
So we have some questions here that we hope to clarify, and as we mentioned, we're going to touch upon those questions we think will assist you in providing more comments and feedback about the workflow. We want to make sure that people not only understand the workflow, but if you have some thoughts, suggestions, you can share those with us. So there is a question about how will the managed care plans be notified of services? Ooh, there's a little echo there.
Move your device away from the speaker.
Yeah. You know what it is? Yeah, I think so. How will the managed care plan be notified of services 1915C children currently receive? And will there be a file set? So as we mentioned, children who are currently with the waivers will be transitioning between October 1st, 2018 to December 31st of 2018. And they will transition their current existing plan of care, their 1915C plan of care, to the new array of services. As we mentioned, we will have a crosswalk provided for those providers based upon their current services today and what they will look like in the new array. Starting December 1st, any completed transitioned plan of care will be sent to managed care plans for those children who are already enrolled in managed care. Do you want to add anything? There's a question regarding slot capacity. As we mentioned, we cannot right now tell you what the slot capacity will be January 1st. We will transition all the existing 1915C children over to the new array. We will be tracking each of those children to ensure that they transition appropriately. Any child who wants to access HCBS services before January 1st will have to go through the current processes today. So however those processes are accessed for Bridges to Health, the OMH HCBS services, Care at Home 1 and 2, and OPWDD Care at Home, those processes remain intact until January 1st. So we don't know how many children will enter HCBS services up until the end of the year, but all the capacities from the 6 waivers will be combined, and then we will know how many children transitioned, and starting January 1st, we would know what the total capacity is.
There's a question here for existing 1915C providers. Do the children automatically transition into the agency health home that they currently receive waiver services with, or can they opt into another health home with another agency?
So I just want to be clear about terminology so that people understand. So, and maybe my state partners can help us. So there's a difference between the provider that provides the HCBS services versus the person who is coordinating those services. And I'm using coordination because I know each of the waiver programs maybe call that person a different title. So that person who coordinates the HCBS services will be transitioning to health home care management, and that child will transition with that person and or agency because it may not be the same person. So it is our intent that all the children with their current providers will stay with their current providers. Of course, if they choose to opt out of health home or not want to transition, or they complete their plan of care or those types of things, but with choice, it's our goal, as we mentioned, that those current providers will transition and maintain those existing children.
Okay. Is the 1-year date mentioned from the date that the child is enrolled in the health home, or for children new to managed care, the date of enrollment into the MCO? So HCBS eligibility, the 1-year date is reflective of the date that a completed HCBS eligibility determination is completed and locked in the UAS system.
And for those children who are transitioning, the date is based upon the completed CAN. So as we mentioned, to go into the health home, you have to be enrolled in health home, and you have to have a completed CAN. That will trigger your automatic 1-year renewal for HCBS services. So it's important for providers who are transitioning children to look at your children, and you have from October to December to transition them, process them through enrollment, and we will outline that for folks. But you can also stagger their CAN so that 1-year determination doesn't all come up for each of your children.
Somebody called out specifically on slide number 11 and numerous other slides in relationship to examples that say not appropriate or appropriate related to the managed care plan. Is this only for kids not enrolled? So throughout the deck, we use submission to managed care plan if appropriate, merely to identify that there are kids who will remain fee-for-service. So you will only follow that step if you are in fact enrolled, a child enrolled in a managed care plan, and would not follow that step or, excuse me, that nuance of the process if you are in the fee-for-service environment. Which follows up with the question, aren't all kids moving to managed care? The presentation seems to be suggesting that some kids may not move to managed care.
So that's true, even though we are changing, sorry, this is Hope from Managed Care. Even though we are changing the who has to enroll in a managed care with this transition, some children will continue to have other reasons why they may not have to enroll in a managed care plan. The most common might be that they have comprehensive third-party health insurance other than Medicaid coverage. Individuals with comprehensive third-party health insurance at this time may not enroll in managed care programs. So we need to be sure that these services are available and accessible by all children that are affected by the transition, and that is why we have designed systems that allow fee-for-service children and managed care children to efficiently and streamline access to the services.
So I just want to be clear that the appendix we keep mentioning is actually on this slide deck. So when we post the slide deck, you will also get the appendix.
One of the questions is specific to the independent entity. What is the criteria for medically fragile? So to be clear, medically fragile is one of the identified level of care target populations, and the target population and all LOC, LON criteria are the same, whether you're served through the independent entity or through a health home care manager. That is the identifier for access and identifying that you meet HCBS eligibility. So as Colette just mentioned, the full LOC, LON content criteria for all 3 steps of that stool are available in the appendix of the document and are for any child looking to access HCBS, regardless of fee-for-service, managed care, health home care manager, or independent entity. People have also asked multiple times whether or not we can explicitly identify who the independent entity is, and I'm sorry to say that I cannot do so at this time.
I'm going to check in now with our state partners to find out if you are considering additional questions or if you've had the opportunity to respond to the questions that you're going to be responding to today.
Thank you. We're just reviewing the questions. So there is a couple questions about the role of the MCO in continued authorization, whether after the first 60 days, is there a continued 60-day review after the initial, what type of review is being done. So there seems to be a lot of questions surrounding managed care, so our friend Hope will answer that.
So I think it's important to recognize that in this proposed process, we are opening up the window to HCBS services without any authorization from the plan being required. But thereafter, on concurrent review, once you've sort of approached the end of the initial authorization period and you realize a child needs continued services, there should be a conversation with the managed care plan about requesting additional services and what is appropriate for the child, the individual, for their use of the service and how they can best achieve their goals. And that continued conversation, we have not at this point in time specified what intervals continued authorization should take place at, imagining that that would be very child-specific and would be the conversation that the provider and the plan have together about how that child reaches their goals and what's appropriate for the child. So if folks have questions about how that authorization process works, whether it's the detailed administrative side of it in terms of noticing or appeal rates or anything like that, I would encourage you to send those in the comments and in the email. If there's a need to explore more about what those kind of conversations with the plans look like and how you go about really having collaborative mechanisms to assuring that a child is achieving their goals in the plan of care, we can also give more information on that. But again, those are comments that I would encourage folks to send through to the email.
Great, thank you, Hope. So there seems to be some confusion regarding the HCBS provider and who is talking to the MCO, and that communication of who determines frequency, scope, and duration. So it is the goal initiated by the health home care manager to develop the plan of care with the HCBS services. So you're working with the family, you have identified their needs, and you're saying these are the types of services we believe would be helpful to your family. The family gets to choose the providers in their local area that have those services. While that plan of care is being developed, referrals are being made to those HCBS providers, and as those HCBS provider referrals are being made, the plan of care by the health home care manager is sent to the managed care plan. It's really important that the managed care plan basically gets a heads up that there's a plan of care submitted and that referrals, which means that referrals have been made to providers. The HCBS providers are the ones that will now determine a scope, frequency, and duration. So they will do their intake process, their assessment process, whatever it is that they have set up to determine the frequency, scope, and duration of the service, the particular services they will provide. They will then notify the health home care manager and the managed care plan simultaneously of those things. So it is a communication process that needs to happen, but one item doesn't have to wait for another. So the health home care managers should be making referrals and notifying managed care at the same time, and the HCBS provider will update the plan of care by notifying the health home care manager and sharing that information with the MCO. So the MCO knows what the frequency, scope, and duration is and will know when utilization review will begin. Anybody want to add anything?
So to provide some additional clarity, as we referenced, when that initial referral is made and that simultaneous plan of care is submitted to that managed care plan, it does not have to include frequency, scope, and duration at that juncture. It's the identification to the plan that they should expect those referred providers to contact them to be able to begin the initial authorization of that service from that provider, and will then be updated to include frequency, scope, and duration per their initial contact with the child and family and additional assessment and conversation, et cetera, to set that. So I hope that provides some additional clarity.
So it might help to also think of it this way, you know, from the managed care side of it, the managed care will get the plan of care from the health home or the IE, and that is the notification that a referral has been made.
and then the managed care plan will be getting that notification from the provider that they've been engaged the child, they've had that first appointment, and that will start that 60-day clock on that initial authorization. So that window for that authorization won't start until the first appointment with the HCBS provider. But if those notifications don't happen to the plan, then there isn't anything that's demonstrating that those services have started. So it is a communication necessity.
There's a number of questions here reflective of some potential confusion about children who will be required to be served by the independent entity. And I just wanted to draw some clarity that both children who are enrolled in Medicaid being served either fee-for-service or by the plan can be enrolled in health home care management or have the option to opt out of health home care management and be served by the independent entity. Those families are not required to be served by the independent entity if they are fee-for-service.
So there's a question regarding the MAP system and the health home enrollment in the RE codes, because right now you cannot be in a waiver program and enrolled in MAP for health home. So yes, come January 1st, those exclusion RE codes will be lifted. There will be information shared with providers regarding any RE code changes.
So as a reminder, based on some of these questions, I do want to stress that while you don't have to be served by the independent entity, you do have to elect to be in a health care management circumstance that provides you a plan of care. So in order to be in receipt of HCBS, you do have to be served by the health home or the independent entity, but you do not have to choose one or the other based on whether or not you are managed care or fee-for-service.
In the middle one? Yeah.
Hi, folks. This is Meredith Ray Labatt from the Office of Mental Health. So there's a question that says, my question is about children who are eligible for HCBS services but does not have Medicaid prior to the enrollment. Is the process still the same where you go through the care system and you're putting in the transmittal 1 and 2, or there will be a new process to have them receive Medicaid? So what you're asking is how the OMH HCBS waiver enrolls family of 1 children into Medicaid and how we use our systems to apply the RE code. So when the care management function within the OMH waiver transitions to health home, there will be a mechanism established wherein there will be a separate and different mechanism for applying RE codes onto children using the alternate data systems, which are both the UAS and the MAP. How and where and how that's working is being worked on within the state agencies to make sure that that is just as seamless as it works today. But there will be a comparable mechanism. It just will not be done within the OMH care system after the transition to health home, and it will lie elsewhere. And TBD on that, more information to come, but there will be comparable processes put in place using alternate systems.
So there's a question surrounding how will communication occur between the health home care manager and the MCOs. So currently, it's a requirement within the health home program that if a child is enrolled in managed care, that their managed care plan is on the consent, the release of information form. So that is added there. So all health home care managers should be obtaining if a child is in Medicaid, in managed care, and who the managed care agency organization is, and ensuring that is on the release of information so that the health home care manager can talk and share the plan of care with the MCOs. It will also be incumbent upon the HCBS providers to ensure that they get proper releases, consents, et cetera, for any types of services or providers that they want to communicate with. So we're not changing any of the consent processes.
There's a great question here simply asking who the HCBS providers are. Are they the same providers today? And to be clear, when we say HCBS provider, we are specifically speaking to those providers who will be designated through our cross-agency designation process as servers of our HCBS service array.
For post-January 1, 2019.
Post-January 1, correct.
Until December 31st, 2018, the HCBS service providers are those that are currently acknowledged under the current 1915C structure.
Thank you.
So again, there is another question that says, if you are in a 1915C and the waiver transitions into health home in November or October, by the way, it says November, but it is October, are the kids still provided 1915C services until January? And the answer to that is yes. So that's similar to what we just spoke about.
So there's a question regarding how the health home will be selected or assigned between October 18 up to January. So the same process today would occur is that the connectivity between the care management agency and their contract with the health home, as well as alignment with the child's managed care plan. So health home or HCBS current 1915C waiver provider agencies should be, if they're not already, making contracts with the local health homes and ensuring that there's connectivity. And after January, those referrals will happen through the MAP referral portal as usual. So there just needs to be some alignment between the child's managed care plan and your connectivity to the health home. And right now, we have each of the health homes have appropriate contracts with managed care plans within counties and regions that they serve. So there should not be an issue if you have a contract with the health home that your child can't be served properly by that health home because those connectivities are already made with their managed care plans.
There's a question here asking us to clarify the difference between youth being served through health home care management and those who are coordinating to transition through the OPWDD MSVs to the new CCO.
Hi, excuse me. Hi, this is Lisa Kennedy from OPWDD. Just to clarify, for those folks, the kids that are in our comprehensive waiver right now, they will be transitioning to CCO health homes. For kids in our care at home waiver, they will be transitioning to children's health home. And for the care at home waiver, you have to be medically fragile and have a developmental disability. For a child to be served in our comprehensive waiver that's going to be moving to CCO health home, you do not have to be medically fragile. So a child in our care at home waiver would have a choice between children's health home and CCO health home. Likely they would probably end up going with children's health home just for continuity of care.
So we would like to take this opportunity to thank all of you for participating and listening in. As we mentioned previously, this recording will be posted. We will send out the slide decks as well as it will be posted on the MCTAC website as well as DOH. And to give you all an opportunity to review it at your leisure as well as being able to see the appendix. Once again, we are eager to hear your comments, questions, or suggestions by next Wednesday, May 30th, in the mailbox that is listed there. And as we said previously, there will be a number of trainings and webinars that will be forthcoming on specific topics as we move forward. And right now, we do have a number of trainings that have been posted regarding our spa services. That MCTAC is starting to present in-person training. So once again, and I thank all our state partners and MCTAC for helping us with this webinar.
And on behalf of MCAC, I'd like to thank all of the presenters, Faith, Colette, and everyone else. And we encourage you to sign up for our listserv announcements so you can hear about these upcoming webinars and in-person events. If your question wasn't answered today, you'll note in the slides that there's an email address where you can submit any additional feedback and questions to our partners at DOH. So thank you very much, everyone, and we hope you enjoy your day.
Dr.